Okay, I am ready. So, thank you for getting this set up. And it looks like this week in particular, we've had a lot of little snafus, perceived or real, having to do with consents. But I think just based on our work, which often has to do with dealing with children who may or may not be able to give their consent. This is something, confusion about the issue is something we see a lot of. So I wanted to talk about several things. One is just to go over what comprises a reasonable consent. Two is the specific subset of people that we deal with, and that's our majority, are the minors, and which one of them can give consent, who can't, and sort of all the permutations of the theme. When you don't have parents there, but you have various other relatives or friends or divorced parents or, all these situations, we're kind of often stuck in the middle and don't know what to do. And the way we'll learn this is we'll go through cases which all of us have seen at least one of, and we'll discuss it. We don't have a big group on site, but just pretend. Anyway, Deb will be our group. Okay, so I think you all have witnessed physicians trying to get consent. So first of all, who should be getting the consent? Who should be the person who's asking for the consent?
Right now, it's the registration.
The registration at the very beginning, but if it's some kind of a procedure, the person who's directly involved. So it rarely is the nurse, right? If the nurse is involved, however, she or he is the witness to a consent, and you should know what constitutes a good one or a bad one. I've certainly listened to some subspecialty resident try to explain a complicated procedure to the family, and the family's Spanish speaking and they're speaking in English, and they think that I'm their witness, and I realize that all the basic elements of a consent are not there. And the most important element is that you have to be able to explain the risks and the advantages of a procedure, the alternatives that are available, what the risks and the advantages of alternatives are, in a way that is understandable to the patient. So if it's a patient who speaks a different language, it should be in that language. If it's a patient who is limited but still can consent for themselves, it should be on their level. And you, as very important providers, I think are in a position where you can say, wait a minute, Dr. X, I don't think they understood that you meant that they're going to cut the leg off, or whatever it is that is coming. So that's, I think, a big unstated responsibility that you have for us as a medical team, because we have to be very careful about that. And if the doctor isn't, then it would be very helpful if a nurse could help us stay the line. There are several types of consents. There are simple consents. And just like the word sounds, simple consents are things that, we do every day that don't have a lot of risks, or they're kind of mundane. So a blood draw, yes, you can create a hematoma, but it's fairly frequent. An IV, it can infiltrate, you can have a bad side effect from it, but that's considered a routine thing. A cat urine. In our situation, an LP. We do so many of them in children, it's not usually considered a very risky thing. So those are simple consents. For those things, it's enough for the doctor to explain the procedure. I am sure typically the doctor leaves the room, the parents turn to you and say, what's going to happen now? And so, these are things that you can help with. For the more complicated procedures, you need informed consent. Examples of those are transfusions. going to the operating room, taking a piece of tissue out, no matter what you're doing. Sedation also falls, deep sedation falls also in this category, and I think we're kind of muddy about the way we do that as far as the hospital policy goes, but we do document. We just don't have people sign a separate consent. The important thing is each institution has its own traditions. The Joint Commission doesn't care how you do it, as long as it's written down how you're supposed to do it and that we're consistent and we all know what that means. So to summarize, the person you're talking to getting the consent from has to be able to understand it. It has to have risks and benefits and alternatives. Simple consents are kind of implied. You, as a courtesy, good patient care, you tell people, well, we're going to start the IV, there might be some bleeding, but blah, blah, blah. Informed consent for the more difficult things should be done by the doctor and should be formally documented on the medical record. And a few of the subsets like surgery or blood transfusions need separate signatures. So the way we do it in the ED, we have three kind of categories. So if the family comes to triage the usual way, we have them assign the consent for admission and service. And the first and second paragraph there really covers a lot of things and is why we actually don't have to get separate consents for every little thing we do. I mean, if you, looks like I had Parkinson's trying to use the yellow marker. But it basically says, I consent my child for, these procedures, x-rays, CT scans, MRIs, blood draws, healthcare services rendered under the general and special instructions of physicians. Then, you have the right to refuse. Photography is included, provided these images can be used for the patient's condition, for surgery, for training, not, oh, this is an interesting rash, I'm going to show my friends kind of thing. But all that is included in our usual written consent. Any comments from our ED leadership about that?
No, that's right on.
Okay, so that's that. The second way is the child who comes without a guardian, and we have to find someone who's responsible and call them on the phone and document it. I actually am not on the front line, so I don't know how often this happens, but Stacy, Teresa, Fran, Deb.
Doing chart audits, I see it happens a pretty good amount.
Yeah,
I
would you
see.
say like
So
10%, 20%?
10%.
10%.
Yeah.
Okay. All right. So you can see that the holes in this are like, you don't really know who registration doesn't really know if the person they're talking to is the mother or not. But the law is very forgiving in that they want two things. They want the best for the child, and they want you to assume the best if someone is advocating for the child. So even if the person's lying, they don't really have, the official custody, but they say they do, it doesn't matter. I mean, if they are wanting the best for the kid and they give you all this false information, you actually are protected by doing your job, getting the telephone consent from this fictitiously related person because you want to do the best thing for the child. So, I think the older we get, the more cynical we are, but actually the law, they want people less than 18 to survive and thrive, and basically how that happens is okay. Yeah.
How about the situations of emancipated minors?
We will talk about that. We will talk about that. Yes, that's a terror. Anyway, sometimes no consent is required. And I think we flail a lot about this. And it's reasonable to do that because the situation where no consent is required is a life, limb, or health threat. So it's dire. So anything that a reasonable person feels would need to be done. Okay, the kid who was struck by a car needs to go to surgery for a laparotomy. the extremity that doesn't have a pulse, like we heard at, various conferences, because it's injured, needs to go to surgery, nobody can find a parent. The kid with terrible asthma can't breathe, the kid who choked on a hot dog at school and nobody can find it. What do? We take them to the trauma rooms, we do what needs to be done, they go to the OR, and then we worry about the parent. And that is what should be done in those situations. Of course, people in the background, the social worker, the registration person, even the charge nurse and other people, in the meantime, try to find who the real caretakers are. But we're not going to delay care waiting for the consent. So any other examples in practice? Yeah, we see this every day.
We've run into what is considered, what you were saying, emergency.
Yeah.
We ran into one consent situation where it was a minor and the person had asthma.
Mm.
And she wasn't dying of her asthma. She
Right.
wasn't in severe respiratory distress. And the parent came back later and said, I didn't consent for you to treat my child for asthma. I prefer to do holistic. You know what I mean? We got blowback for how we treated her. The prudent person, of course, a reasonable person, is that we would give an albuterol to the patient. Would she die without the albuterol?
No, and California law is, like you could see, life, limb, we all understand that, but it also says health.
And we prevailed, but it became a question.
Yeah, and we should have immunity, and I hope that our risk managers support us?
Absolutely, we prevailed. It just made people question that life and limb thing.
Right.
So,
because you're right. I have some examples like, well, how near death is this? How close to the, I can kind of feel the pulse, is that, no, if you have license to do what you think is reasonable. This also brings up the question, we know that things change every 20 years in medicine. I know, for example, that when I was a medical student, in all seriousness, I remember going to the bedside of these old people and saying, salmon is a very fatty fish. You shouldn't eat it. It's bad for your heart. Well, and this is what we thought. So there might be some things that we do now that we think, I don't know, albuterol, that we think are essential that in 20 years, people will say, oh yeah, in the mid-2000s, people used to, give albuterol. So things change, but to the best of our ability, the state-of-the-art knowledge, we think albuterol is necessary for respiratory distress. This is what we use. We are protected. We have immunity in the law. Okay, so the things that need consent in RED are generally under snapshot in EPIC, and this is an example of a bad slide because you can't possibly read it. But if you look under the snapshot, there is a category called consents and forms, and all the things on there generally need a consent that is signed. So you print that out and you sign it. And things like transfusions are on there. What is on there? Stuff that we don't usually do. Acupuncture is on there. That's my little baby, and we do that anyway. So you can see all this stuff. Lumbar puncture is not on there.
Is laceration repair? I'm looking, I didn't see it.
No.
It's not on.
No.
So it doesn't require consent.
It requires a consent, like me talking to the family and documenting it on that procedure part of EPIC, which often has discussed with the patient or the parent, but it doesn't require printing this, having them sign it, giving it to the clerk so they could scan it in and put it in the media tab.
Because not to hijack, but along that asthma, laceration repair has been an issue as well. And
Okay.
it's been where they're at a field trip.
Yeah.
A kid's at a field trip.
Right.
And the kid falls down and gets a laceration, a cosmetic laceration, let's just say that. And the teacher, the person who has that field trip consent, brings in the kid and says, well, yeah, the reasonable person under health or whatever would suture this laceration.
Yes.
Right? And the parents have gone berserk and said, I would have gotten plastic surgery. I'd have gone to my private doctor. I don't like that first-year residents, so did I.
Well, that's an interesting point. I think we're safe with that, but I will, I will ask specifically about that.
Because that has come up, I got
Yeah.
a giant avalanche in Alameda about this exact thing.
Very interesting.
Because starting when my children started school,
Yeah.
on that consent for field trips,
Yeah.
I would say life and death only is what I would sign. Used to do.
Well, maybe that is, I think we're protected because, how is the teacher supposed to
I
figure
didn't
that
want
out?
the
But
teacher
you're
to
right.
take them to San Ramon Region.
Well, right, or to some, yeah, you're absolutely, so I don't know, in that, I think we would be protected, but, being protected is not the same as, you'd still have to meet 100 hours with administrators and the risk manager and everybody else.
For a bad outcome, even if you consent, they'd
Right.
say, I would have gotten a different clinician.
Right.
I don't know, it's just, those are the consents that get
Yeah,
asked of me a lot.
well, that's an interesting, I'll ask that,
That was
Stacy, in the next permutation of this lecture, I'll have that, but for right now.
No, we're good, I think we get the concept, it just, those
Yeah.
ones that you're not gonna die if you don't suture that up in 4 hours.
Right,
You know,
exactly, that is true, yeah, but how would you know? Because some parents would be more than happy that you did it, and some parents, you look at the zip code and decide that, of course you can't.
Right. But unless you write something very specific like I did, no teacher in the
Right,
line
right.
would taken one of my kids to an ER.
So elective, okay, that's an interesting. Okay, who can give consent? So I kind of alluded to this. Obviously, the parent who actually has custody, not the parent who's, if a child is a foster parent, it depends what the court has decided about medical custody with the child, right? So these are things, the domestic partner of a parent, only if the court has awarded them that right. Babysitters, if there already is a little note from the parent saying they can do whatever they need to do. When they're divorced, if they have joint custody and one parent doesn't want it and the other parent wants it, if it's not life-threatening, you theoretically can't do the procedure until they agree. OPD makes a decision if the youth is in custody because they have the court-ordered documentation. But I think in all of these cases, again, if it's life-threatening, it doesn't matter who has custody. We do it. If it's not life-threatening, we call social service and we try to figure it out. And if it's one of these things like the facial lack, let's say, so theoretically 12 hours before horrible scarring. So it's 11 and a half hours since the kid fell on the field trip, but they had to get back from Yosemite and, that's how long it took. Well, I think you can, in fact, sew it up then. But if it's 2 hours and you've got another, 9 hours before the 12 hours is over, then you have the ability to find the family. And the decision, I think the nurse and the doctor should talk about this, and I'm sure that registration would, and the charge nurse and the primary nurse would bring this to the attention of the treating doctors, right? But so who can give consent is kind of immaterial in an emergency case, and when it's not emergent, then you have to have the legal guardian. This is what people are supposed to sign ahead of time that shows them that the grandmother, in fact, has the rights to make a decision for the child. And this is also a good faith thing. She just kind of signs it. You really don't check to see if she has any kind of court thing that says, yes, she's in charge. Okay, who's a minor? When can they consent for himself or herself? This speaks to your stuff, Deb.
So going back to the consent of the grandma, what do you mean that they should sign that ahead of time? Like have a piece of paper that they give to grandma that they present to the ED?
Right. It should be that if the grandmother, say, takes the kids during the day while the parents are working, the grandmother should have this consent affidavit. But if she doesn't, our registration, this form is from our administrative manual. Our registration people could give her that form and she could fill it out. And what it says on it is that, the mother or the legal guardian gave me permission to take care of this child, and I bring the child in and I'm making the medical decisions in lieu of the parents. And you're never going to know if that's true or not, right? You are just going to have to trust. But the law supports us because we are doing something for the life, limb, or health of the child. So it's very lenient as far as we go. And I think if the mother and the grandmother later, the mother said, "How dare you take my child to children's," so those two could possibly have a legal interaction, but not us. Who is speaking?
Kim Rock.
Oh, Kim.
I believe.
Okay, I haven't seen you, Kim, let alone heard you in a long time. Anyway, okay, who's a minor when they can consent? Okay, so anybody 12 or over can consent to outpatient mental health. They can't be put into a mental hospital without their parents, but they can get outpatient mental health. Any kind of STI, HIV, drug or alcohol stuff, and they get HIPAA protection. And that is one of the reasons we have the option to send the ABS home with a child by printing a limited sensitive ABS that doesn't have, specific diagnoses on it. And theoretically, the law allows them to get a bill for it, so eventually the parents find out. It used to be that they could not get a bill for it, but the law allows them to get a bill unless the pediatrician ahead of time has made arrangements to get them on one of these grants, which of course doesn't happen most of the time. But if the mother calls up later and says, "Johnny was here he said he was in the emergency department and I want to know why," we can't tell them why they were here, and because they can consent for themselves. Yes.
If it's one of these
things. Yes, if they fell down the ladder and broke their leg, that's a different story. Yes. But this has been a big thing. People, the nurses who have children this age are like, "This is preposterous. You mean my 13-year-old is not, just finished 8th grade and is not even in high school and is going to be in the ED and getting treatment for who knows what, and I won't." Yeah, but that's the California law.
How when a parent calls on the phone and asks if I heard my child's there.
Oh yeah, we have some cases about that. Well, we have some cases about that, so hold that thought there.
How about the child who comes, not the child, the minor with a child? Is she?
I've got questions about that. Okay, I've got all those things. Okay, any age minor, 9-year-old can consent for reproductive health. I would like birth control.
I thought it had to be up. You mean up to? I thought it was 10th birthday.
Any age. It's any age. However, we're going to talk about that. You have to ask how old the partner is.
Yeah. Oh, that's right. Oh, because they can't.
Yes, if they want reproductive care and the partner's 15 even, and they're not, that's terrible. That's okay. Emancipated. So this is emancipated minor can consent for all their care. So that is a person who's legally married, in active duty, or who can prove because they have a DMV card or a little notice that they have been living independently of their parents, and therefore they also sign all the forms that say they're going to take care of all the bills. And I don't know that and anybody over 18, of course, can sign for themselves. What were you going to say?
I was just going to say, if a runaway is living independently of their parents,
yes, Well, that's an interesting, okay, let me.
Emancipated minor, or do they
Well,
have to
it
have a
depends.
card?
No, the fact that they're a runaway, well,
Thank you, that's what I have to go.
No, they don't, they just have to be independent. The official documentation is that they have a card. I might have a picture. This is the self-sufficient minor attestation, and they signed this. Again, they signed this in registration. So how do you prove it? You don't, right? So it's an interesting thing.
And I use the example of runaway, but they probably wouldn't admit to us they're a runaway.
Yeah.
Because then we call the
Yes,
social worker.
that's right.
But if they, not theoretically, if they are actually living independent of their parents and couch surfing with friends or whatever.
We sometimes see these
Then-
kids who, where do you live? I live at my girlfriend's house and I don't,
Yeah.
So I don't know if I live in my girlfriend's house and the girlfriend's mother feeds them. And she doesn't, you have to be financially, taking care of your financial affairs. So I think sometimes these are quite loose. I'll ask about this.
But the overall gist of what I'm hearing you say is that they sign the paper, they attest to that they're independent, and we take them at their
Right.
and legally,
We're
we
protected.
can't sit there and say, you're a liar, I'm not.
Right, exactly, or I'm gonna have to prove it.
Yeah.
Now, we probably, again, if something was a life threat, we have a case like that, then we would do whatever we needed to do anyway, and we would disregard them, right? I mean, it's kind of, so it's like, we let them have the rope, even if it's not deserved, as long as they're not hurting themselves, and we are protected. Yeah, perfect. Yeah. So infant needs an LP, resident explains the procedure to the family. Does a separate consent need to be signed? Well, we know that in our institution, no. A lot of the residents who come from other hospitals say, well, really, you don't sign a consent, even UCSF. So that's a little different, but we don't need to in the ED. And what about blood transfusions? Yes, IND, no for photos. And this,
No for photos, is that what you
no,
said?
we do not have to. I talked to Denise Joyce and it's in our signing thing.
What kind of photos?
For training, for documenting an epic.
I thought you meant, okay, that's.
Yeah,
not-
no, so when I was
Not
taking my
marketing photos.
pictures, my, aesthetic pictures for my Berkeley photo course, of course I got permission. Yes.
Any kind of marketing thing as well.
Yes, any marketing, any non-medical use, non-medical or non-medical teaching use.
Okay, good.
And the recent video we did, I got a consent for anyone that got near the front of the camera.
Yes, exactly, that's a great, okay.
Did you answer I know I stepped out for a second, there's a code green, which is kind of hilarious, that a code green on a 20-year-old? I thought it's like.
Oh, that's interesting, well, unless they're medically.
I know, but I just thought that was
challenged.
interesting.
Yes, very interesting, from the consent point of view.
20-year-old is a graduate from high school.
Oh,
That's different.
very interesting.
I know, so they're looking for him.
He's just missing.
So what did you decide about, you answered about the
Well,
parents and the child?
if a kid says they're independent, there is a form that they can sign. It's this one from Triage, self-sufficient minor attestation. Again, they are signing it at Triage, right? So we don't have to prove.
No, but we have a child, an 18-month-old, 15-year-old, that's the mother, parent of the 18-year-old, and the 35-year-old grandma.
We're gonna have a situation, no, a
Good.
self-sufficient is financially independent, is
Right,
not,
so
has
the
nothing to
15-year-old
do with
cannot
whether you're
consent for
pregnant
herself.
or not.
Correct.
Yes.
Okay,
It has nothing, this is the, the teenage boy, DeMarie, when he was 15.
Yes.
He didn't live at home, he had his own little job or whatever he did, and he consented for his own care. So, and what Teresa and I were talking about is, as long as you're kind of doing the right thing, you don't question them, or I don't believe you, or, prove it, you don't have a DMV card. The law specifically states that you are not you're not encouraged to try to have them prove it and delay care. You know, because you're doing the right thing for them. It's, you're allowing them license to get care, and they will be financially liable for all the care that they get. Okay, resident finishing a lac repair, attendings doing a sedation, resident asks you to explain the LP to the family of this patient. And the resident says, gee, you've been here much longer than I have anyway. I know the risks and benefits much better. So is this okay? No.
Not really.
No. So what I would want to communicate to my nursing colleagues is absolutely, you have to talk to the attending, and some doctor needs to get the consent. So what if the primary caretaker isn't there? The patient requires an urgent but not emergent procedure. The attending tells you, Teresa, I spoke to the mom on the phone and she gave her consent. So what are you supposed to do?
You have to have two people.
Yes. So you, in our policy, our hospital policy says that you, Fran, can then call the mom back. I understand you spoke to Dr. Saulys just a few minutes ago about the procedure. I just need to verify, blah, blah. So that's okay. But ideally, we both should be on the phone at the same time.
But it doesn't
not
have to be
waste it.
simultaneous.
But it doesn't have to be, but you do have to, our policy says you do have to call and kind of make sure.
I have to hear it with my own ears.
Right, exactly. And then you document it. Yeah, exactly. Okay, what is this? This is consents policy. Patient-specific consents may, I need to make this bigger so that,
Well, it's
what does it
policy
say?
19, right?
Basically this is, you can do anything, wait, what does it say? Second paragraph.
Legal and ethical duty to obtain consent prior to medical treatment, except cases perceived to be an emergency.
Yeah.
The second paragraph.
Yes.
Patient-specific consents may need to be obtained in the ED. They can be obtained from the Epic Electronic Medical Record under the snapshot
Yeah.
activity.
Yeah, I think this is one version before I cleaned it up. So this is just, all this says is basically, where you can get, and we already saw these extra little consents, and that an emergent case does not. Oh, this is, okay, look at this one. This is from our emergency nursing stuff. Specific consent for the procedure not required for the lumbar puncture. Verbal consent following a discussion, which even our risk manager wasn't entirely clear about. But
It's because inpatient, they get consent for lumbar puncture.
right, and they do in a lot of EDs, but we do so relatively many. I mean, maybe not these years that we're tapping in general less, but you do have reasonable documentation in Epic, even though you don't find, parents somewhere in there. I thought it said, well, I think actually in this one, in the sedation one, it does say who you talk to. In this one, it does not.
I think you definitely have to say what you're gonna do.
Yeah, you do have to say it, but I think this consent documentation in Epic for an LP does not have, I spoke to the parent. It does in the sedation one.
It definitely.
Yeah, in the sedation one. In this one, it does not. So, it is kind of weird, but we do, the residents generally do. Okay, all right, pregnant girl comes in with a painful ingrown toenail, which she wants treated. Her mom is not reachable. So this is, the case we kind of all brought up. Why did I put this in there? Well, this is not, okay. So patient is a minor. She really can't consent for herself. In an emergency, which is determined by the medical screening exam, when the consent can be obtained, it's implied, allows providers to save the life, limb, or health of the patient. Providers have immunity. Law is applicable, blah, blah. So then you have to decide whether, you can, so I think, you could say, well, that toenail is going to affect her health. But you could also say, well, you know what, this is really not an emergency. So I think we have a lot of leeway. And frankly, I think if the place were falling apart and we had other things that were really worrisome, we would say, you know what, this is not really an emergency,
Well, we
you
would
can go see
medically
Dr.
screen
Kim.
them.
Yeah, oh, you have to medically screen everyone.
Yeah.
I think I screwed up this presentation. This is not the way okay, let's do this next case. So she comes in 3 months later with her newborn who has a fever. She tells you her other foot hurts, and now you see the second ingrown toenail. So, which is the right answer? She can consent for the baby's fever workup, but not for herself. You can't fix her second ingrown toenail. She can consent for the baby and herself since she's now a parent. She can consent only for herself since she's no longer pregnant.
Wrong.
So the right answer is A.
Yep.
Really?
Oh, yeah, it's definitely A. Years ago, they used to say if you were pregnant, if you've had a baby or are pregnant,
Right.
years ago, they used to say you were emancipated.
Right.
You are no longer
It's not.
emancipated just because you've given birth.
Correct.
And that is the thing.
Right. Now, if you're living by yourself with your boyfriend, you don't have to be married, but you're financially independent. Yes, you're an emancipated minor. You can decide for yourself. Okay, what about this one? Same 14-year-old girl comes, and the newborn has a fever. She tells you her other foot hurts. Now you see the second ingrown toenail. The teen's mom is in the room. You discuss an LP for the infant with the teenager. The teenager absolutely refuses the workup, but the grandmother says, go ahead and do it.
We've had that.
Yes, or you discuss the LP for the infant with the teenager. The teen agrees, but the grandmother says, no way. Yeah, we've had that too.
Have you watched that show, Unexpected?
No.
It would clarify your life.
Really?
Yeah, because it's all about this
This
exact
kind
thing.
of stuff?
The teen mom living with her mom was the age of where mom, grandmother, and great-grandmother all live together because they're all under 50, basically.
Yeah.
But anyhow, and the same thing happens when they go.
Right, right. So basically, if the kid needs an LP and we need to do it, it doesn't matter what they say. We get social worker, we can get CPS, and we can do the LP. What we usually do is we try to pick our battles and say, somehow it was hard to get through to either of these people. We would talk to social work. We would probably come up with some palatable alternative, like give the kid antibiotics and admit them, or just admit them or something. But basically, we would do what we have to do for the kid. But theoretically, only the teenager can consent for her baby. The grandmother cannot. So, we'd have to work on both of them. If the kid needed it for life threat reasons, we would go ahead and do it. Okay, 12-year-old girl comes in with her mom, abdominal pain and bloating. She's been having irregular periods for about a year. The beta-HCG is positive. I think a lot of people have issues about this because they have kids this age. And what do you mean? You can't tell the mother, but you can't tell the mother of this child that she's pregnant. And we've gone through this a lot. We get the social worker, and I think 99% of the time we can, after 3 hours, convince the child to tell her mother, and then it's a reasonable thing. So she comes in, wait a minute, okay, that's all right. Oh, this is where if you have a young child who's either pregnant or wants birth control or something like that, you have to ask the age of the partner. And if you look on this algorithm, and in California, if you have a 13-year-old child who is having sex with a 14-year-old, that child has a mandated report to Child Protective Services MAID. If the child is, you can see the CJ means clinical judgment, mandated means mandated, and basically, you only have a few years leeway usually, either way. I mean, it's interesting that somehow the 14-year-old can, so the 14-year-old can't have sex with the 12-year-old or 13-year-old, but clinical judgment on having sex with 14 to 20-year-olds. I mean, it would have been very difficult.
Specific, so
no,
you can.
That's a good point. I wasn't thinking of this. This is very interesting.
You got the 20-year-old girl with a 15-year-old boy. He is not allowed to be having sex with her. hello, teacher.
Well, but age of partner, so it doesn't matter. So 15, yeah, I see what you're
That's what I just said.
So 15, yeah, clinical judgment, yeah. Well, I guess the clinical judgment is very, yeah.
He explained it to me as age difference is an issue as well. So a 20-year-old woman and a 15-year-old boy, man, young kid, whatever, that would be not, it's reportable because of the age difference for one.
Well, according to this, it's clinical judgment.
Well,
It's
that's
not.
fine. I think that's,
Yes.
but I mean, he uses that as
Right.
to
That's a
influence your
very
clinical
good,
judgment.
you know, okay, we're gonna change this so
But
that we
the-
have this part of the discussion.
This particular graph, the M's,
Never.
the
Mandated reporting.
mandated means that's a legal thing you have to
Yes, you
report.
have to
This
report it.
is
It doesn't
written in law
matter.
somewhere.
I kind of, you know, he's my 13-year-old boyfriend. I mean, you would think a 14-year-old patient having sex with, I mean, we're not talking should they be having sex at all, but a 13 and a 14-year-old having sex with each other, you'd think like, well,
Who cares?
yeah, who cares?
I mean,
They're
other
kinda-
than.
Yeah, I mean, they both might be in 8th grade or 9th grade, but it's mandated, so,
Interesting.
He explained all this to me and I can't remember why.
who did?
Jim Crawford.
Oh, Jim Crawford.
He would
okay.
always exactly.
You know what? I'm gonna have to, this is a very good thing. Okay, 14-year-old comes in by herself to complain of abdominal pain, vaginal bleeding. Her point of care urine, beta HCG is positive, Ashcon diagnosis on ectopic. The Alta Bates OB floor has accepted her. Which of the following is true? Unless she's hemodynamically unstable, the ambulance cannot transfer her without the mother's consent. Well, she's pregnant, so she can.
It's 911 we triage anyway.
911. Patient can consent for herself and be taken by ambulance without further ado.
Yes.
If she's unstable, yes. The patient can consent for herself, and if she refuses transport, you have no recourse but to sign her out AMA. And actually, we have a trauma policy. I think I gave you the wrong thing. Okay, look at this. It is the responsibility of the patient's physician to fill out the . If the guardian consent is obtained, okay, but if the parent's consent cannot be obtained for transfer, and transfer is considered an emergency, like an ectopic that's bleeding, and you have to go to Alta Bates, the physician must document on the transfer consent form that it was considered emergent, and out she goes.
And so you can do this without the parent's consent.
Right.
Well, she do it anyway because she's.
She's a minor and she can only consent for her unborn baby, which is not yet born and is not a baby yet, is a fetus. So in her situation, her medical consenting must be done by her legal guardian, and the guardian is not there, so she can't really say she's not going to Alta Bates. You know, I'm sure we've had these situations.
We definitely have.
What do? Do we do this? I mean, this is what our policy says.
We transfer.
I mean, and I wonder, you know, like if I was the receiving hospital, I guess, you know, she's pulling out the IV, she's refused, well, let's presume that she's hemodynamically, and of course we'd have everybody talking to her and trying to convince her.
And how far along, how pregnant is she
Right,
and all that.
exactly.
If she's impending delivery, she's not
Right.
making decisions on behalf of herself or her unborn child.
Right.
And so someone has to protect the unborn child. I mean, there's a whole big
Right.
thing.
Right.
Well,
if she's unstable and it's a life threat, and most ectopics would be considered that,
They are.
she has to go whether she wants to or not. And in the other situations, it's the AMA form, and that's our AMA policy. And basically, you know, I think if the patient is stable and you document that, you can have them sign out AMA. It's not a good protection.
no, it's not worth the paper it's written
And
on.
this is a whole nother lecture, but we have a lot of problem with the accident victim parent of the child who comes in and needs treatment but refuses transfer.
Oh, yeah.
So that's not really a consent issue, but it's along those lines of the AMA form and whether or not we actually do the treatment for somebody
Sure,
who needs to
who
be
themselves
on
needs, and
triage.
we can't provide them, you know, their
Right.
neck hurts and they just have their seatbelt thing on there, yeah.
But we've had that, and they're not, then we consider that they're not making decisions on
Right.
their, it's less, traumatic trauma. It's worse if it's a stroke.
Of
And they're
course.
refusing care, and then one could argue they're not making appropriate mental decisions.
Right.
And that this happened to us with someone.
Well, I'll ask
Pretty
that, I mean, it's great to have this discussion, which I presume there's not a huge audience, but we can revamp this a little for, for these real situations and get some input.
We wouldn't want anyone to act independently on these without,
No, that's a
clearly
very good, yes.
consulting either the attending, the manager on call.
And the attending in situations like this should not work independently.
No one should be acting independently.
Right.
Yes.
So the reason I got motivated to write this lecture is because one of our longtime nurses and I had a disagreement about a patient like this. And I think a lot of people would have had a disagreement because she had children this age. And 17-year-old boy, obtunded, seems drunk, brought in by his friends. A woman who says she is his mom calls, asks to speak to his nurse. Marianne pages you overhead. You answer the phone. The woman asks, "What's wrong with my son?" And although the boy's vitals are stable and he can maintain his airway, the tox screen has come back positive for marijuana and his alcohol is through the roof. So what can we say and what do we? So the person in question identified very strongly with the mother. She herself had been through a similar situation, and I think told her everything. So you can tell the mom everything. Your son was using marijuana, he's drunk, he'll be better when he sleeps it off. You tell the mom her son is here, he is stable, she should come in and see what's happening herself. You tell the mom that according to California law, you can't tell her anything about her son's condition. I think most of us would have pity on the frantic parent on the line and do B. But the ideal thing is you have to have C. You can't tell her anything.
But I always say when I'm trying to reinforce this is when you do B or A, the parent holds it together, brings the kid home, beats the crap out of them at home, and they come back to us as a trauma stat full.
Oh, that's a great
And that's-
tip.
We're the person on the phone, it's not the mother.
Well, that too.
Right, and
But I'm saying-
that is the big point. How do you know?
Well, you don't. You're not allowed even if it was consentable, blah, blah, blah. It's you cannot, Jim Crawford told me this too, that you do on what you think is the prudent parent would want.
Right, exactly.
And they hold it together till they get home, and their naughty kid is
Well,
doing this for
the
10th
prudent
time.
parent, however, and this breaks down a little because I think most prudent parents would be like, "What do you mean? The kid's like, what do you mean you can't tell me? Is he alive? Is he there? Is he, or
Yeah,
is
but then they come in and they're mad at you, the clinician, for not
Right.
telling them. They could shoot you. And then they'll also take the child home and discipline them how they see fit.
But I would say, so, I see what you're saying. I would find it hard not to tell the mother
Of
that
course.
he's
we all know
stable.
that.
He's stable, but you have to come in.
I think the
See
bigger
where
thing
he's
too is he was out all night and he ends up,
Right.
like you hear stories where moms called 5 ERs trying to look for their
Right,
kid,
exactly.
and she's in misery.
Right. I mean, but I think to tell her that he's stable with nothing else, I would probably do that, frankly, although by law, you have to say, "See, sorry, ma'am, I can't really tell you
The
anything
good
because
thing
of
with
what
C
you're
is
saying."
it kind of says a lot. C
Yeah.
says, "I know your kid's here," is kind of what C
Right,
says.
right.
Because the answer to that is, in the absence of, I can't tell you anything by California law, most people, Marianne, would say, "I don't see him on the board." So the parent would move on
Right.
to call out the base.
Right.
What also seems a little bit contradictory is that we're able to call the parent or registration and confirm their
Yeah.
identity for
Right, right.
yeah, but we're not able to
Agreed.
give out information and confirm it that way.
But not in a sensitive service like that.
Yeah, and no, it's yes, and that's That's it, Kim. This is a sensitive service. So I don't know, these are great. I think we're gonna tune this talk up. We're gonna tune it up.
Presumably, if he gets brought in by his friends, we're getting his name and birthday and stuff.
Okay, well,
Close
there's
enough
one
to
with
the
his
person.
friends. There's one with his friends. But here's another, okay. So he's mildly intoxicated this time. He's brought in by his friends. He tells you he's been drinking at the prom and asks you not to tell the parents. A woman who says he's his mom calls and asks to speak to the nurse. It's the same old thing. Marianne pages you, and so what do you say now? So this was actually the scenario. The child was not. So, this is kind of the same thing. It's absolutely the same thing. And he asked, so some people argue that in the first scenario, the kid was unconscious and, was kind of like in a dire strait. And of course, the parent needs to know about it. The parent needs to know the kid's in a dire strait if they're in a dire strait. And then, if they come in, you truly don't know, they call and the child, is doing badly, you ask the parent to come in, then you can talk about marijuana and you can talk about the alcohol and all that stuff, in a life threat situation where, he's being intubated and the blood pressure is falling and all that stuff. But the first scenario wasn't that bad, and this scenario definitely, the kid asked you not to tell. And if you, they can actually sue the nurse and the hospital if you tell. So I think the answer to the first case and the second case is you really can't hold them on anything but ask her to come in. What about this one? I've had this one. Okay, same kid. He's brought in by his friends. He sleeps off the alcohol and the marijuana, and he's ready to go home. Friends say they can drive him. So is the answer, you can send him home with his friends because he came with them. He can't go home until his parent is contacted and the parent gives consent to let the friends drive home, or he can't go home until the legal guardians come to get him. B is the answer, really. You can, if the parent, again, do you believe that the person you're talking to on the phone is not the older sister versus the parent? But if you document that they say that, they know who these people are and can drive home, then fine. But you can't say, well, he came with them, so he probably can go home.
So in this case, you call up the parents.
Yes.
And you say, your son is in our emergency department. You'll have to talk to him about why he's here. But is it okay with you if his friends drive him home?
Yes. Okay. Isn't that? And if you're a savvy parent, you probably, then your antenna are up and you know exactly why he's there.
Hop in your own car.
Yeah, exactly. So, yeah, I went over all of these with okay, 7-month-old baby sustained a fractured lower leg. You suspect maybe non-accidental. Dr. Crawford suggests a skeletal survey, but the parents absolutely refuse because they don't want to subject their baby to that much radiation, and they can't. Even if it's just a small suspicion of non-accidental trauma, the doctor has the right to do it. And I guess, if we have problems, then social service, the sheriff, everybody else. But we have the right to do anything that requires evaluation of non-accidental trauma and keeping the patient safe.
So you don't have to do a court order and all this other stuff. You can just say.
No, you can just say, sorry. Have we ever had this happen where they didn't want to do it?
I imagine we have, but I don't know of any that didn't get to yes, as Stacey was saying, eventually. I don't know. Not that I can think of.
It's kind of, well, this is another get to yes situation. Divorced parents, shared custody, kid has appendicitis, Dr. Betts wants to do surgery, mom agrees, dad has recently been reading about the antibiotics in Europe, and he thinks the anesthesia risk is too high, he doesn't. Well, medicine is changing about this thing, and I think you do try social work and all of that, but ultimately, if appendectomy was absolutely necessary, the kid would go to the OR, and you would decide this later.
Yes, you have to get a court order if they can't agree.
Well, if the kid is, if it's a ruptured ampy, the kid's hypotensive, if it's a life threat, the kid can go. But if it can wait, because now antibiotics some people actually do antibiotics, then, it would be a social service,
But sometimes it's
Denise
not even-
Joyce, nurse administrator on call, or administrator on call.
It's definitely happened with diabetic care.
Oh, really?
Yeah.
Like what? Like,
I don't think,
like a DKA not treated?
well, that's extremist.
Yeah.
More like, I don't think he needs insulin. I think we can control his diet. Parents don't agree on the
Oh,
treatment course. I don't think he needs to be admitted. I can take him home. He just didn't take his shots. I can take care of it. So there's definitely, I've heard that before. And that's consent for admission more than consent for treatment, really. I just know that, the appendicitis thing, I've seen it, most of the time parents will agree at the end.
at the end.
When you threaten to do nothing, they'll agree.
If you have two parents that will not agree, and don't you then kind of have to find two physicians that agree?
Listen,
That's
well,
the
you have to get a court order.
You do not, so that's what Dr. Betts thought. Denise Joyce, because we talked about this kind of at the trauma M&M, I was going over a case like this, but you don't, Denise Joyce says you don't need two physicians.
You just need one.
Yeah, you just need one to say that this is kind of a life threat.
But these people in the room, physicians, were saying it's gonna be hell freezes over before they take someone against their will.
Right, well, that's true. Even if you're right, this family is going to sue or whatever it's going to be. So I think, if the kid were hypotensive and he were dying, nobody would care. They would just take it.
It's the ones
Right,
that.
but this one probably can, in fact, wait for Denise Joyce to come down and for there to be whatever safety stat or something, whatever would happen. So what would you tell your nurses? I would ask them to call the administrator on call. I would ask them to get the medical legal person.
Not them.
What?
Tell the attending, call the manager.
Oh, okay, like can they call the person for me? I could say to the charge nurse, please call. And then you or Teresa can get
And
the
the
ball
nursing
rolling.
supervisor is another one who is in a leadership role.
But see, I think this needs, the ED is falling apart, everybody's doing
Well,
it.
that's why the
and
nursing
you
supervisor
need the
can do that.
legal person.
That's right, the supervisor calls the administrator on call as well as the legal person. I think that would be the most streamlined way and not a lot of telephone. So,
And that said, the day that I needed it for the autopsy or for
oh
the
yeah, that's right.
coroner's case, we don't have a legal person on call.
I know,
today.
but you called me, but yeah.
I know, but I just think there's holes in this
But
thing.
there's huge holes in the legal thing.
Yeah.
I've tried for hours and hours and hours to get a hold of them
Yeah.
before. It's not at all hard to get a hold of the administrator on call.
Right.
Who definitely will drill down and do that. That's always where I.
Okay, well, so when we rebut this,
It's
we
sad,
should,
it's the same person.
And I was gonna say the administrator on call, say our risk manager is in Europe. We have at least now the West Bay risk management
Yeah,
people,
there's
so
some
the
others, yeah.
administrator on call would have a contact for sure.
It's a thing, but you gotta get to a correct answer. Oh, boy.
well, we'll redo these things because we'll give it.
And we have had, one parent insist on going to a different hospital and one saying this hospital's fine. And that's happened to say.
Oh, God. Well, this is the Jehovah's Witness, and this is the kid who's anemic because he drinks too much milk and he
Oh, yeah.
needs a transfusion, but he looks basically fine. So he also is a social service kind of thing and, get Howard Rosenfeld involved and do this sort of semi-electively. But the kid who is a full trauma and he's unconscious and his belly is blowing up and he needs a transfusion, he's going to get a transfusion. And it doesn't matter, you will try to respect them as much as possible. But my experience with this is the family is relieved that you take it away from them and you are the one that made the sin and not them. Okay, oh, this one, I didn't even remember. A 13-year-old comes in by himself from school. He's got, oh, this I added. I didn't think I'd have a long enough presentation. Because of abdominal pain and persistent vomiting, he confides in triage that he's been vaping marijuana daily for the past 2 months. It helps his anxiety and that he feels like he feels like killing his very strict and overbearing dad. So the issues are, well, he's a minor, but he does have this drug thing that should be confidential. On the other hand, the fact that he's got a homicidal ideation puts all confidentiality out the window. Yeah, I mean, true, consent for himself, if another person is in danger, so obviously you call a bird. And I just wanted to go over this because I think we're seeing a lot. And how the characteristics are, and some of the things that help are the capsaicin cream that you use for muscle aches and pains that specifically targets the vomiting receptor, CB1 vomiting receptor.
Where do you
So
put it?
on the abdomen usually, or on the outside arms, and any area that otherwise the person likes to have the hot water from the showers on.
Oh,
Because that's the other treatment. Showers at 41
I know that I've
degrees.
seen the capsaicin put on abdomens that have not seen the light of day,
Oh, yeah.
and it causes an inflammatory, it's like putting hot pepper.
Well, but that is the point.
Yeah, but it
Most
causes a skin
symptoms.
problem.
Oh, well.
I've seen dermatitis, contact
Okay.
dermatitis, it's bad.
So most of these are boys. They all have nausea and vomiting. We had a girl the other day who had come in 3 times, had a complete workup each time. And basically what the history turned out to be, and I didn't think of this myself, it was one of the Highland residents. Oh, cannabis well, of course, yes, she's vaping every day because she's anxious. And, the only thing that really cures it is stopping it. But the other thing in the history is they used their family's hot water completely because they stay in these showers for hours, and it's cyclic. And they keep coming back, and fluids, Zofran, but most importantly, Haldol. That really calms them down. And now ketamine, I guess, ketamine's used for everything. And then the capsaicin cream, just tells you, our pharmacy doesn't have it. But that's,
The capsaicin,
yeah.
it's sold everywhere.
No, I know it is. But for our ED to put it on, it doesn't have it, so. Anyway, so that's it.
And ketamine at the